right, everyone, we are going to get started. It's after 5:30, so I would like to welcome all of you and thank you for tuning in virtually. As many of you know, and I know some of you attend our prostate cancer awareness lectures every year, we always do a lecture in recognition of September being Prostate Cancer Awareness Month. I would like to thank you for joining us. And if you have questions, I wanted to turn your attention to the Q&A box on the bottom of the screen. So if you have any questions for our speakers, you can just type them in there and we will take questions at the end. And with that being said, I'm going to turn the program over to Dr. Stacy Loeb, who is our first speaker, and she is a urologic oncologist here at Pro-Mother Cancer Center. So let's welcome Dr. Loeb.
Hi, everyone. Thank you very much. Great to be back this year for Prostate Cancer Awareness Month. So this is really just some general information about prostate cancer and prostate cancer awareness. The prostate is this little organ in the pelvis near the bladder, urethra, and rectum. It is not needed to live. It has some function in reproduction, but is really causes a lot of problems as well. And the way that it is typically monitored is through the PSA, the prostate specific antigen blood test. So that's exactly where it is located. High-priced real estate, and that it is in the midst of a lot of very critical structures. These are the current 2021 cancer statistics from the American Cancer Society. You can see that prostate cancer is the #1 cancer in men in the US and second leading cause of cancer death. There are some non-modifiable risk factors for prostate cancer. The risk of prostate cancer does increase with age. There are certain racial and ethnic groups that are more likely to be diagnosed with prostate cancer, and individuals who have a family history are more likely to be diagnosed with prostate cancer. Of course, family history does encompass several different constructs. There is the genetic piece, and that is what Lucas will be discussing later, as well as shared environment and behaviors that family members often have, such as eating the same kind of food, living in the same latitude with a certain amount of sun exposure, etc. And of course, screening practices, because if someone in your family has been diagnosed with prostate cancer, then you're more likely to get tested. So all of these factors contribute to what we think of as family history. So how heritable is prostate cancer? That has been looked at from twin studies comparing the rates of prostate cancer between identical twins and fraternal twins. And those studies suggest that somewhere around 50% of prostate cancer is hereditary in nature. So that's very high compared to other cancers, actually, but that still leaves the other half of things open to lifestyle and other modifiable factors. There does definitely seem to be a lot of differences in terms of global incidence patterns. You could see the darker colors on this map, which is in grayscale, are the higher incidence areas. So we've got North America, Australia, Northern Europe are some very high risk regions, much lower risk in some other parts of the world. And interestingly, migration studies show that coming to our country causes these individuals to be at higher risk. So there's been some very interesting studies of Japan. Asia is a low risk area for prostate cancer. They eat a diet that is more plant-based with a lot of soy products and a healthier lifestyle. And Japanese individuals who move to America have a higher risk than Japanese people in Japan, and really intermediary between Caucasian Americans and Japanese people in Japan. So definitely moving to the United States and adopting lifestyle patterns actually influences the risk. It's very interesting when you mesh this all together in terms of some of the lifestyle factors and the incidence maps. Like if you look at it, the top is milk consumption around the globe, and the bottom map in the red is meat consumption. And they overlay, pretty interestingly with the prostate cancer map, so the more dairy and meat in the diet, the higher the risk of prostate cancer. So those are some of the foods that are concerning in terms of prostate cancer risk: meat and dairy. Some foods that are potentially beneficial include tomatoes, which contain lycopene. This can help to prevent prostate cancer. Also important for people who have prostate cancer. Same would apply to cruciferous vegetables, things like, broccoli, collard greens, nice green vegetables. Soy is also thought to be beneficial. Fish in some studies is beneficial, although there is a little controversy there. High coffee and tea intake have actually been associated with potential benefits for the prostate. Good news if you love coffee like I do. I think this is something that's important to be aware of as part of cancer awareness, that the World Health Organization classifies processed meat as carcinogenic. This includes things like hot dogs, bacon, and salami. So they are considered known carcinogens, causes cancer, the same category as smoking and asbestos. The next category down, probably causes cancer, includes beef, pork, and lamb. So these are things that we would also want to avoid to reduce the risk of cancer. Why is this the case? Part of it is high temperature cooking that is required for most meat products, which releases heterocyclic amines, which are carcinogenic. There's also a lot of hormones and hormonal effects from meat consumption. But even in the absence of these things, just the nutrient composition is different. It's more inflammatory and has lower levels of anti-carcinogenic compounds compared to plants, which have fiber and other antioxidants. Another important factor is obesity and physical activity. It's known that obesity increases the risk of advanced prostate cancer, and that physical activity can lead to a small reduction in cancer risk and mortality. So the American Cancer Society really emphasizes all of these factors are in for prostate cancer: maintaining a healthy weight, doing at least 150 minutes a week of aerobic physical activity. We would also recommend doing both strength and flexibility training in addition to the aerobic physical activity. Eating a diet that is high in fruits, vegetables, and whole grains, and avoiding smoking. So just to summarize, plant-based diets are healthy and reduce the risk of fatal prostate cancer. Exercising and maintaining a healthy weight is also important. So while this is a cancer that does have a very strong genetic basis, there is still a lot that we can do and should do to try to reduce the risk of fatal prostate cancer. Another important component of that and reducing the risk of advanced or fatal prostate cancer is screening and early detection, because prostate cancer does not have any symptoms at an early stage. And therefore, the way that it is found early at a time for cure is typically through screening. Screening is mostly done through PSA, which is a blood test. The PSA goes up when there is something that's happening in the prostate. So the good news is that the PSA typically does go up if there is something going on. The bad news is that that something isn't always cancer. So the PSA can also go up if somebody has an infection or the prostate is just growing. So it's not a perfect test because it's not perfectly specific for cancer. It's called prostate specific antigen, not prostate cancer specific antigen. That being said, if it goes up, then it's kind of like when the check engine light goes on in the car. It tells you that there's something happening and that we need to open the hood to check what is going on underneath. And there are definitely many ways to look into that to determine if it's from cancer or one of these other issues. Screening does have pluses and minuses, so it is very important to talk to a physician about it and make a decision together. This is a process that we call shared decision making, and it involves sharing of information back and forth between the patient and the physician. So we actually recommend talking through this process and this test with your doctor, talking about the advantages of the test in terms of early detection of prostate cancer at a time when it wouldn't cause any symptoms, but also the disadvantages. And I mentioned some of these earlier, that it's not a perfect test for cancer. Some cancers are indolent, and it can screening for prostate cancer or other kinds of cancer can lead to overdiagnosis of tumors that may not have caused problems during somebody's lifetime. And knowing about one of these cancers could lead to, worse quality of life, anxiety, and other issues. And it's always important to share your own preferences and values with the physician as part of this process to provide the most patient-centered care. So some of the benefits of prostate cancer screening, as I discussed earlier, are earlier stage at diagnosis when hopefully curative treatment is possible. Because it detects cancers earlier, screening is associated with a reduction in metastatic or spread of prostate cancer and fewer prostate cancer deaths. So if we didn't screen at all, we would likely diagnose more individuals at a more advanced stage in the disease, and the rate of death would go up. Now, there was some reduction in screening during the COVID-19 pandemic. This study was a bit concerning. This was by my colleague, Dr. Chen, and he and his colleagues charted how you could see with the blue line there, which is 2020, there was really just a pretty dramatic plunge in PSA screening rates during the height of the pandemic. Not surprisingly, the good news is it did seem to rebound after that, but I just don't think we fully know yet what the full impact of the pandemic will be in terms of prostate cancer. Now, in terms of some of the harms of prostate cancer screening, you can get false positive results. If the PSA goes up, it may have just been an infection. It could be because the prostate is growing. Benign enlargement of the prostate, or BPH, is a very common condition in men where the prostate grows with age. It can cause a lot of urinary symptoms, and it's annoying, but it's not cancer. So that can cause some confusion with the test. Less commonly, there are false negatives where the PSA is not elevated, even though there's cancer. That's not very common, but there's some very, very aggressive cancers that are so poorly differentiated or so aggressive that they just don't make much PSA. So that can happen, but not as common. The best that we can do is to try to look out for some of these factors. For example, we don't want to check PSA when someone is known to be in the middle of a urinary tract infection, because then it is going to be high. It's going to be a spurious elevation, and then we're going to get all scared that there's something wrong, but we know that infection makes the PSA go up. And I think it's important for patients and the public to know about this too, because I actually see a lot of people who somebody sent a PSA test while they were being treated for a urinary infection. And then, it was high and it caused a lot of anxiety and more tests. And it's just a really unfortunate sequence of events. So better to wait until the infection is over and treated so that we get a good result that's reliable. Also, since PSA does have false positives, the good news is that there are some other second line tests that we can use now to follow up on the PSA results to try to help sort out if it went up, is it cancer or not? So there's blood tests, urine tests, and even MRI that can be used in men whose PSA goes up to try to sort out what is actually happening. Now, in terms of next steps, so after somebody does have a PSA that is concerning, the next step in the process may be to get MRI or some other marker, and ultimately to decide whether to have a prostate biopsy to check for cancer. Prostate biopsies involve needles into the prostate. This can have side effects such as bleeding or infection. Also, as I discussed earlier, this process can lead to overdiagnosis, where maybe there's such a small tumor that's not at all aggressive that it never would have grown or caused any problems during someone's life. And so by doing all these tests, we unearth that tumor, and that patient may have anxiety, they may get treated, they may have side effects that didn't need to happen. And this is just a recognized problem that can occur with screening for different types of cancer. If you give people who don't have any symptoms a lot of tests, you may unearth incidental findings that might never have otherwise come to light or caused any problems. And, we see this a lot with other things in the field of urology. We see patients who maybe they had a car accident and they got a CAT scan or x-rays, and then it shows that there's something on their kidney and they didn't know about that, and they're not having any symptoms. And now there's a lot of anxiety, but it may end up being nothing. So this is not a problem that is exclusive to prostate cancer screening, but the more tests that are done, the greater the chance of picking up something. It could be something important, or it may be something that is not as clinically relevant. So how do we mitigate some of these problems or tackle some of these difficulties? One of them is just to try to reduce some of the downstream side effects that can happen from screening. We have some new approaches to make the biopsy better and safer. There's a lot of new treatment options for prostate cancer. There's been a lot of investigation into, for example, focal therapies, treating only a part of the prostate in selected patients rather than the whole prostate. Many more men are also getting active surveillance, or actually not doing any treatment up front and just following the cancer over time. And so that's a very good option for people who have cancers that are a lower risk. In terms of treatment selection, if you are diagnosed with prostate cancer, my best recommendations are to really do your research and use trusted sources of information. Multidisciplinary consults, or talking to different kinds of doctors, can be very helpful. Most prostate cancer is diagnosed by a urologist. There are also radiation oncologists and medical oncologists who manage prostate cancer. Talking to different kinds of doctors about the problem may give unique perspectives and help you decide what to do. This is becoming even easier nowadays because of telemedicine. This is one of the best things to come out of what has otherwise been a very challenging couple of years in our country with the pandemic. In fact, just within the field of urology, only 16% were using telemedicine before the pandemic, and a more recent survey, 46%. So it more than doubled during the time of the pandemic. It's rapidly increased here at NYU, and this makes it even easier to see different kinds of doctors to get information about this. There's also a lot of information on the internet, and that's a very commonly used source of information about prostate cancer. The majority of internet users do look online for health information, and a fair number of people also use it to look about health information for other people or to find others who experience similar health problems. I would just say a word of caution about this. This is an example YouTube video that is describing injecting herbs into the prostate to treat prostate cancer. This is not evidence-based and is not recommended in the guidelines, but this video had more than 300,000 views. So this really worried us. We did a full study on this topic to see what is the quality of online information. And in this particular study, looked at the 150 first YouTube videos about prostate cancer. And unfortunately, the majority of them contain information that was not very good quality, potentially biased or misinformative. And these videos were seen by millions of people. So you really do have to be very careful about the source of where the information is coming from and also the date of the information. There are some positives, though, about online information. For prostate cancer, for example, I've been working with the Prostate Cancer Foundation, hosting a prostate cancer journal club through Twitter. It is indexed under the hashtag ProstateJC for those of you who use Twitter, and many different physicians from different specialties, scientists, and also about 1/3 of the people who participate are not in medicine. So this is a great way for the public to engage with physicians and scientists and other types of healthcare professionals about the latest important research in prostate cancer. So I would just summarize, it's important to check the source and the date of online information and ask your doctor for additional sources of information. It's recognize that, you know, the clinical encounter with the patient and the physician is very time limited and that many people want more information. So don't be shy to proactively request additional sources. And I could say the Prostate Cancer Foundation, they have some really excellent information and a patient guide about prostate cancer that's great. So in addition to the Prostate Cancer Foundation, some other great sources are the Urology Care Foundation, Us Too International, and Zero Cancer. Pretty soon, we're going to be releasing a podcast focusing on prostate cancer genetics. So hopefully we'll be able to help get more information out there in that way as well. So thanks very much. I'll stop my share now.
And I'll go ahead and share my screen. So my name is Lucas, and I'm a genetic counselor at the Promoter Cancer Center. I'm with NYU Langone Health. And I have no conflicts of interest to disclose. So like Dr. Loeb was saying, prostate cancer is unfortunately fairly common, and about 15% of men will be diagnosed with it. And we can break this into 3 segments when we think of it from a couple of different perspectives, specifically about how this cancer is arising. Dr. Loeb described prostate cancers that can arise from aging, due to lifestyle, due to a variety of different things, and we consider those sporadic, meaning that they happen by chance. And then there are 2 other sections that are similar, familial prostate cancer and hereditary prostate cancer. I'll be focusing on the hereditary prostate cancer first, but hereditary prostate cancer means that there is a gene when we do a genetic test that is increasing someone's risk to develop prostate cancer and is the large driver behind their diagnosis. And the familial prostate cancer, like Dr. Loeb was saying, is we can see prostate cancers running in a family. Maybe it's due to shared environments, maybe it's due to other factors that are passed down in families, but we don't necessarily have that one single gene that we can identify at this point in time. So focusing a little bit more on the hereditary prostate cancer, we'll first talk about some genes and some basics around that. So We have 2 copies of every chromosome in our body, one from our mother and one from our father. And these chromosomes are made up of DNA. DNA is essentially a string of letters repeated over and over again, and it can be broken down into smaller segments called genes. And these genes are the instructions to make proteins in our bodies. Proteins are what make us human beings and keep us alive. And we know that there are specific genes that can protect our bodies from cancer, or are working to protect our bodies from cancer. Usually, when these genes are working properly, they just create a healthy protein and things go about as usual. But sometimes we can find a change in these genes, whether it's an extra piece, a missing piece, some changes of the letters swapped around, and it creates a damaged protein, a protein that's not functioning properly. And in these genes that are usually protecting our bodies from developing cancers, that's where these increased risks can come from, because those genes are no longer working properly. So when we're talking about these genetic inherited factors to develop specific types of cancers, including prostate cancers, usually what happens is a person just has 2 copies of a gene. It's working just fine. As they live their life, maybe something happens and they have a mutation that causes that gene to not work properly. But we still have this other gene that is making up for it. And this gene can, kind of work as a stopgap to cover that gene that's not working properly. But as someone continues to move forward through their life, that second gene may begin to not work properly, and that can lead to a tumor forming, as you can see here. For someone who carries one of these genetic mutations in one of these cancer predisposing genes, they're born with one of these genes already not working properly. So it takes less time for that tumor to occur, because you get that one, as you live your life, that one exposure that is knocking that gene out, and then that tumor is occurring. So we see the cancers associated with these genes, these gene changes, usually occurring at younger ages because of this reason. We do not, however, see someone who is born with a change in one of these genes immediately develop a tumor. It usually has to happen over time for that to occur. Some of the signs that we look for with these hereditary cancers, specifically hereditary prostate cancers, we look for people's personal medical histories. We're looking for metastatic prostate cancers. We're looking for high-risk prostate cancers, including things like high Gleason scores, specific tumor grades, and high PSA levels above a certain amount. And we also take into account people's family histories. So we're looking for things like multiple family members diagnosed with prostate cancers, other types of cancers that can be genetically related. So for example, breast cancers, ovarian cancers, or pancreatic cancers can be genetically linked to a risk for prostate cancer. Early onset cancers before the age of 50, and specific backgrounds like Ashkenazi Jewish heritage are associated with these specific gene changes as well. So I'll talk about one specific example, the BRCA2 gene, to give a little illustration about what we look at when we get a result back for a patient. So the BRCA and BRCA2 stands for breast cancer. And that was because that when this gene was first discovered, it was associated with just breast cancer. But we found that there are several types of cancers associated with the BRCA or the BRCA genes, both BRCA1 and BRCA2. For the BRCA2 gene specifically, individuals that are born with mutations in this gene are at an increased risk for developing several types of cancer. We'll get into that in just a second. And also more aggressive prostate cancer diagnoses are associated with this gene as well. But BRCA2 is not the only gene that is associated with an inherited risk to develop prostate cancer. As you can see, this is from one study. They did genetic testing on men with prostate cancer diagnoses, and these are the host of genes that they came back with. And so, we're learning more about which genes are associated with increased risk for prostate cancers every day. Sticking with that BRCA2 example though, those specific cancers that we see associated with this gene For men, prostate cancers and breast cancers, with a 20% lifetime risk and a 6% lifetime risk respectively for both of those types of cancers, which are above the general population risk to develop those specific cancers. And we also can see that women have increased risks for the BRCA2 gene changes as well, things like breast and ovarian cancers. And then both men and women associated cancers are pancreatic cancer and melanoma at increased risks or elevated risks. So as you can see, these genes can show us several different types of cancers that people can be at risk for, and also they can affect both men and women. So you say, well, great, you know about these risks associated with these genes. Is there anything we can do about that? Most of the time, yes. So we have specific recommendations to minimize people's risks to develop these specific cancers. So for example, starting prostate screenings earlier, doing clinical breast exams and self-breast exams for men, or even adding in mammograms for men with gynecomastia. And then for women, increasing the amount of breast screening that they're having, potentially considering specific types of surgeries to reduce their risk for cancer. So it's not like we just know about these cancer risks and say good luck. A little bit more about genetic testing. So as I was describing before, genetic testing is like a spell check. So we're reading through those specific genes, like the BRCA2 gene, letter by letter, and we're saying, are there any extra pieces? Are there missing pieces? Are there changes in these letters to identify mutations that could increase people's risk to develop cancer that show that this gene is not working properly? And there are some specific benefits to genetic testing. Understanding a person's specific cancer diagnosis, understanding potential risk for other types of cancers for that individual. It may impact the type of treatment that somebody can consider having. Things like a PARP inhibitor, immunotherapies, or even platinum-based chemotherapies sometimes need a specific genetic change in order to qualify for those types of treatment. And then also for family members, this information can be important. We're talking about inherited genetic changes that are passed down in families. And so there's potential risk for children, siblings, nieces, nephews, cousins. It impacts a whole family once we find a genetic change that is associated with a cancer risk. Some additional information about genetic testing. It is much faster turnaround time now than it used to be. It used to take months to get genetic testing results back, and now it can take about 2 or 3 weeks on average. The out-of-pocket cost is much, much lower than it used to be. It used to be thousands of dollars. Now the maximum out-of-pocket typically doesn't exceed $250. And even then, we're finding that insurance is covering a lot of the cost to do this testing, and a lot of patients have a $0 out-of-pocket. Medicare covers the cost of genetic testing for men with metastatic and high-risk prostate cancers. And there also are some sponsored no-cost genetic testing options that are available through different research studies, through different programs with different genetic testing labs. And a lot of times we're able to connect patients with that as well. Talking a little bit more about that familial prostate cancer piece. Like Dr. Loeb was saying, prostate cancer is one of the most heritable cancers. And we find that men who have a first-degree relative with a prostate cancer diagnosis have about a 2-time or 2-fold increased risk to develop prostate cancer. And that risk can increase if there are more people than just one individual, if there's closer relationships. Ages of diagnosis can impact as well. And so just because someone has negative genetic testing doesn't mean it's necessarily at the end of the road. We're continuing to learn about these genes associated with prostate cancer. And so we recommend that repeat genetic testing for those genes occur in the future, in a couple of years, 5, 10 years, maybe even, to see if there are new updates to the field that we can offer patients to help understand their familial risk for prostate cancer. A little bit about what I do as a genetic counselor, just to give a little bit of background on that. So I talk with patients very similarly to information that I've been sharing with you today. We go through a personal and a family history. So we're going over personal medical history, exposures to different things, diet and lifestyle, cancer history, and I build a family tree with patients as well to see how cancer is moving in a family and what types of cancers are present. We also go over some patient education pieces, risk assessments. So I look at a family tree and a person's own personal information that they've shared with me, and I synthesize all of that and I say, you know, what is the likelihood of having one of these genes present in a family to help someone get an idea of what their risk may be. And then we also go over some basic genetics education, talk about specific genes and cancer syndromes like the BRCA2 gene. And then we also help a patient come to an informed decision around genetic testing. We don't want anyone to ever feel like they have to have genetic testing, that they're being pushed to have genetic testing, because it's a very personal decision. It's a lot to learn about your own cancer risk. It's a lot to learn that you could potentially have passed this risk on to other family members. And, you know, this is impacting not just one individual, it's impacting the whole family. So sometimes people like to take care around making this decision. A little talk about direct-to-consumer genetic testing, just because sometimes people have questions about, you know, I've done a 23andMe, is that a comprehensive genetic test? 23andMe can be a fun little thing that you can do to kind of understand, you know, heritage or ethnicity, or find other family members or things like that. But sometimes there are things that aren't so great about doing testing, like a 23andMe or an Ancestry.com. Things like learning about who actual biological parents were that they may not have known about, learning about relatedness of individuals being closer than one expects. And so direct-to-consumer genetics may provide a false sense of assurance or security for patients. And we find that specifically for people that are looking to understand their cancer risks sometimes. 23andMe was approved by the FDA to have the ability to offer genetic testing for the BRCA genes, BRCA1 and BRCA2, but they're only available to test 3 specific locations within those 2 genes. And those specific mutations are associated most commonly with the Ashkenazi Jewish population. So if a person is not of Ashkenazi Jewish descent, it probably won't pick up anything on this testing and give that false sense of security of, oh, well, 23andMe said that I'm okay. You know, there must be some other explanation for all this cancer in my family. In actuality, there are over 1,800 genetic mutations that incur an increased cancer risk just in the BRCA1 and BRCA2 genes alone. We also know from that pie chart that I had shown earlier that there are other genes than just those 2 genes associated with an increased risk to develop prostate cancer. So I give this air of caution to just relying on those direct-to-consumer type tests to understand someone's risk for developing an increased risk for cancer. I'll talk a little bit now about a specific study that I'm and Dr. Loeb are involved in called the TARGET study, which stands for the Technology Enhanced Acceleration of Germline Evaluation for Therapy. The TARGET study is looking to improve 3 different areas. First with providers, so people like oncologists, urologists, and primary care doctors to make sure they have accurate tools to be able to assess someone's health history and help them find genetic testing. For patients themselves, we're working to increase access to quality genetic testing, clinical-based genetic testing, so they can get accurate information about their risks. And could potentially qualify for different types of treatments and therapies and share that information with their families. And then also just general population awareness. So there are social media campaigns that are going out to increase awareness around this link between genes and prostate cancer. We've developed a patient education web tool to help increase the education around that link between the prostate cancer and genes. And it includes 9 different modules of both video and text that patients go through to help them understand the link between those 2 areas. And then if this is something that they would like to move forward with, they can talk to a genetic counselor about genetic testing. So here's an example of what one of these modules looks like. So it has, you know, a video that a patient can watch and then also some text that they can read. So that's my talk. Thank you all for listening. And my contact information, if you would like it, to talk either about specific questions or if you're interested in the study or inherited prostate cancer.
Thank you so much, Lucas, and thank you, Dr. Loeb. Both of your presentations were so informative, and we really appreciate you speaking tonight. And before we wrap up, I have a few questions here. Dr. Loeb, this one is for you. How often do you recommend PSA testing for men over the age of 70 with a history of slightly elevated levels?
Yeah, I mean, this is a great question. Many professional organizations do not recommend routine screening over age 70 for the population level. At the individual level, I think it's just an individual decision between the patient and their physician based on their overall health and risk factors and their preferences. Some patients do wish to continue screening, especially if they had a history of elevated levels or are at increased risk and if they're otherwise healthy. Thankfully, prostate cancer tends to be slow growing, so it's less likely that someone will have a cancer that rapidly progresses and leads to death. But there are also many men in the 70s who are very fit and healthy with, well above a 10-year life expectancy, in whom screening could continue to provide benefit.
Okay, and we have another one. What is the difference between a PSA test versus a free PSA test? And would you recommend having both?
That's a great question. So PSA can circulate in the blood in two forms, either bound to proteins or not bound to proteins, which is free. So the total PSA level, or the main PSA test, measures both. It measures everything, and the free PSA is just the proportion that is not bound to proteins. And you want that to be higher. The way that I memorized this in medical school is you're free, so more free is a good thing, unlike many other tests where a higher level might be concerning or scary. You want more of the total to be in the free form. So we typically look at the percentage. And I think this is a helpful test. So we don't necessarily get this test on everyone, but if the total PSA is in a borderline area, then the free test is very helpful to sort out whether we're more concerned about cancer or a benign reason for that elevation. So I guess in the short version of the answer to your question, typically the total PSA test comes first. But if it is in the borderline range, let's say it's 3 or it's 5, then we usually repeat the PSA anyway after 4 to 6 weeks if there's an elevation, to make sure if it's really confirmed or if it was just spurious. So at the time of that repeat test, it's a great idea to get the free and the total level done.
Okay, thank you. And that looks like it is all the questions for tonight. So Dr. Loeb, Lucas, I would like to thank both of you so much for joining. That was an excellent presentation. And thank you to everyone who tuned in. We will also be posting this footage on our YouTube page and our Facebook page. So if anyone wants to share the footage with a loved one, or if there's something you missed tonight, we will have the footage for you. So thank you, everyone, and have a great night.